it is taken up, same old routine, taken up by antigen presenting cell. It takes it up, breaks it up, and puts on MHC. This is an MHC, your gene, and this is a antigen over here, and presents to cells, right? It can present to a T cell, or it can present to a B cell. Okay? In this case, B cell is important because we need to make antibodies, right? So B cell takes that, right? You can see the way it's drawn over here is a separate one. So this is for the T cell and this is for the B cell. Okay? Because B cell has antibodies attached over here, which are IgD, right? And this is also a B cell receptor as compared to this guy over here, which is a T cell receptor. So far so good? So both of them work together like incredible movie Mom and Dad. One makes cytokines and the other makes antibodies. But in the overall picture, what happens is that most of the time we need antibodies, and antibodies especially for allergies, right? You can see over here it says induction factor of type 1 hypersensitivity. So we are talking about IgE specifically. Okay? This is what we discussed. Now again, the same story, antigen is presented, Ig is produced, and this IgE then adds to the top of the receptor, which is Fc receptor on the mast cell, right? And it can also act on basophils, another cell, and it can also act eosinophils, right? And then again, it releases all those mediators that we talked about, and these mediators could be preformed or inflammatory mediators like histamine, which are going to cause various effects. Most of the effect is vasodilatation that lowers the blood pressure. So if you don't treat this guy over here, your blood pressure will fall, you'll go with anaphylactic shock and you die. So this happens for any other situation where any antigens enter into the system, right? This is what we discussed yesterday as well, that there has to be a cross-linking of the two. There's a cross-linking as we discussed yesterday. I gave you an analogy, and then again, calcium is important as a secondary messenger because it is going to release these granules from here. And you can see it has cytokines, IL-4, IL-5, IL-10. It has other tons of cytokines which are there. So what you need to do is that if you were to design the drugs, which I'm discussing right now, you can either play with IgE, play with cytokines, play with these guys over here, or in the end, do the symptomatic treatment. So that's a bigger picture. Now on the same side, if you go to 13.8, in this case what's happening is that there is a worm on the mucous membrane of intestinal. Worm infestation, very common. And the idea is destruction of a worm by eosinophils that have migrated. So the idea is pretty much the same. It could be a mast cell, right? But it could be any other cell that bears the IgE receptor. So there are IgE receptors on these cells. You can see from here. And the worm releases an antigen, which could be anything, and this antigen binds the two receptors, right? And this concept for binding, again, is a cross-linking, as we discussed yesterday. Cross-linking, right? And that triggers the release of cytokine. Pretty much the same situation. And the mast cell or eosinophil specific, because eosinophil is very specific for worms, okay? And they degranulate, and once they degranulate, they're going to release all those things, which, as I told you yesterday, is like a pharmacy. So you will have histamine, the major player, and you have many other factors that are going to increase inflammation. So you can see the vessels will leak out, and the antibodies are there. They are going to come bind to eosinophils and then increase the permeability. So the permeability is increased. So the same situation is that one of the mechanisms that we also find that the IgE created through this pathway, right, also can attach directly to the worms. You can see this is another worm coated with IgG and IgE. Right? In this case, the only difference is that both antibodies are involved. IgG, which is a bigger player, and IgE, right, to eosinophil. So the cell is eosinophil, especially for worm, as compared to mast cell, which was there for all the antigens, especially asthma, asthmatic antigens, dander, and so on and so forth. But this is specifically for the worm antigen. So when you talk of worm antigen, keep that in mind that this is specifically for worm destruction by eosinophil. So eosinophil is also a cell that has a lot of granules, eosinic granules, as you drew yesterday, mast cells. But the attachment again is IgE antibodies. Okay, so far so good? Yes?
Yes.
The concept again, degranulation, releasing and causing increased vascular permeability and inflammation and so on and so forth. So keep that in mind. Now we have to design the drugs. As I said, the table 13.1 is the most important table. Memorization, you know, rote memorization. I have no clue as to how you help you for that. But if you look at asthma, for example, one of the things that we do for asthma, because in asthma it is vasodilation for the vessel, but bronchoconstriction of the respiratory tract. Because respiratory tract is filled in with all those things that are leaked out. The fluid, the cells, they form a mucus there. All these things kind of block the bronchi and unable to breathe the oxygen, right? So you need to dilate that. So use bronchodilators. So all these bronchodilators again, albuterol, you know, epinephrine, all these are specific. They are going to work on different receptors on the respiratory tract and have the effect, you know, in terms of primary beta-2 adrenergic activity. So these are all first line of defense that you want the person to take, because that's the immediate symptomatic. If it happens to be asthma, but if it happens to be the circulatory system involved, CVS, then you have to deal with other things in terms of steroids. So if you look at the treatment, they usually give them the bronchodilators and steroids, puff. But if it's very severe, then they have to give tablets. If it's very severe, they want to give injection. So that's how, because type 1 hypersensitivity, as I said earlier, is going to kill you. Okay? And you can see the treatment for use is asthma, bronchitis, right? Exercise-induced bronchospasm, acute attacks of bronchospasm, you know, all these things which are going to cause chronic or acute respiratory failure. Regardless of what causes it, we need to dilate it. So all these are the agents that you're gonna learn also in asthma, right? In allergies, especially if the allergies are causing respiratory symptoms. You agree with that? Regardless of the cause, because we're not worried about the cause, we want to save the person. Otherwise, I said that if it happens to be pollen, you can avoid the pollen. If it happens to be dander, you can do all those things, but by the end of the day, you have to relieve the patient and make sure the respiration takes place. The other thing that you can do is that you can give a immunotherapy, which is, as I said, a new thing's coming up. And most of these immunotherapies are the monoclonal antibody, which are called MABs, monoclonal antibodies. Abbreviation is MABs. So any drug that you want to remember, it says MAB in the end, it's an antibody, which is an immunotherapy, whether it's a cancer, right? So this particular antibody, what it does is, it binds to the antigenic sites on IgE and overlaps with the Fc receptor. So what happened is that if for example, which one is better? Well, let's see. So if this is a Fc receptor over here, okay, and Ig is going to sit over here and cause the reaction. So what we do is we're going to block that. Block this antibody, this receptor. We block this receptor. If it is blocked, then the antibody is not going to act. So antibody against the Fc epsilon R1, right? Thereby inhibiting the ability of the IgE to bind cross-linking and stimulate degranation. So that's pretty much the game, the concept of this antibody, which you will have to remember if you understand the concept per se. Simple, because mast cell has a Fc epsilon R1 receptor where IgE binds, and you want to block that. No binding, no cross-linking, no release of. So you basically are stopping that happening. Does that make sense? Inhibit the ability of IgE to bind. Simple. Ig is there, but it's not going to do anything. Right? And when do we treat that? When there is a corticosteroid resistant asthma. You are giving corticosteroid to block inflammation, and the patient is resistant, so you have to go for alternative therapy. Because you have to keep in mind, one therapy is not enough. So don't think that the asthma person will only have this inhaler, no. Or steroid, because anything can fail. Anything can fail. You understand this concept? Or chronic idiopathic urticaria, which is like a skin disease. It can cause inflammation of the skin as well. Steroid is not working. Patient is having problem, itching, redness, pain, swelling. As I said, that monoclonal antibodies are the drugs of the future. Very specific, block the receptor, help the patient. It's called immunotherapy. Okay? Now the other game is that you can see from here, what is happening is that these, when they degranulate, they release histamine or histamine-like substances. They produce chemotactic factors for neutrophil. What's happening is you need chemotaxis, so you go chemotaxis of neutrophil. So what are neutrophils going to do? They're going to come and cause tissue destruction. What is pus? It's a neutrophil. It's going to cause tissue destruction. So your tissue will be damaged. That's not good. Okay, that's not good at all. Or you will have other mediators, as we discussed, which are going to cause different effects. So we need to block that as well. So what happens in this case is, the other pharmacological activity is that other than these, we can also use xanthine derivatives, right? Other set of bronchodilators, right? So they relax the smooth muscle, so they go for other type of action. The other one was beta adrenergic, which is like more of a autonomic nervous system. The other is you use a muscle relaxant on the spasm of the muscle that is caused, right? And you can also say it relaxes smooth muscle of bronchi and pulmonary blood vessels, inhibits mast cell degranulation. That's a two action, one action and two action. Very good, right? So if a person has a severe attack of bronchial asthma, so we use the treatment. What is apnea?
Problem with breathing.
Stop breathing, not problem. Stop breathing. Apnea means stop breathing. Ap means absent breathing. No breathing. Apnea. And bradycardia. And bradycardia. What is bradycardia?
Slow breathing.
Say it again.
Slow breathing.
Oh, you got it. I'm gonna fill you back in physio. If somebody doesn't know bradycardia, I'm gonna go back and fill.
Slow heart rate. Slow heartbeat.
Say it again.
Slow heartbeat.
Slow heartbeat. That is a blunder. You know, these terms, they're gonna kill you in clinical if you don't know that. You don't know tachycardia, bradycardia, arrhythmia. Brady means slow. Cardia means heart. It's a cardia is heart, nothing vessel, right? and prematurity in infant. That's another issue. Now, the last line of drugs that we have, because they're going to ask you the pharmacological action of the drugs. You know, in medical school, we're not doing the pharmacy. What they do is they have a written part, they have an oral part of exam. The written part, you can do whatever you want to do. You know, you can memorize, you can write, you can cheat, you can do whatever you want to do. But when you come oral part, then you address the person directly. So you know it or you don't know it, right? So this is a concept you have to have, right? So in this case, the whole is, as I said, mast cell stabilizers. That's the name of the game. So you want to make sure that the mast cell that contains all the nasty things, which is full of all those mediators, newly synthesized, you know, recorded, we don't want them to kind of, it's like a, what do you call it, time bomb. We don't want that. It's a grenade. you want to hold it. So what you need to do is you want to make sure that nothing happens on this membrane, stabilize. We don't want anything happening, we want to secure that. And the best line of drug, the most expensive, they keep on the, because the more work they do in immunology, the more expensive it becomes, right? So the cromolyn sodium, right? Claritin, correct? Claritin. So this is decreases or prevents mast cell degranulation. So what, keep in mind that nothing is perfect because there are
You're saying that that's another name for clarity? Is that one?
Sorry again?
You say clarity? Is that one?
No, that's a commercial name, but the real name is cromolyn sodium. The actual substance is cromolyn sodium. Keratin is the company's name. It can come in different names. It just got famous. It's just like, you know, Viagra. The company makes it, but it's not Viagra per se, it's something else. Does that make sense?
Yeah, it was just listed in another one, so that's why I just wanted to make sure.
Yeah,
But
there are
they didn't
tons,
list it.
yeah, there are many, but the agent is cromolyn sodium. But keep that in mind, it says prevents calcium influx, right? And you remember, where was that? Where did I put, did you guys put the calcium over here? Over there. So you can see from here, we talked about the role of the calcium as a secondary, yeah, there you go. This is good because that's also a mediator, so we make a drug out of it. So that's also where the claritin is going to act. And they ask you, these are like pharmacological questions. You need to know 3-4 mechanism of action. It decreases or prevents. This means nothing is perfect. We try our best. Sometimes people say, I took claritin, it didn't work well. You're not claiming, we say either it prevents or decreases. It's not 100% because alternative pathways are there, right? So what we do, treat or prevent mild bronchospasm. Right? So severe, they're not taking, you can, if it's severe, you have to do steroids or better drugs. The other drugs are leukotriene modifiers. Right now, if you go back over here, when the antigens of the the antigen of allergen causing T cell, it is going to release these cytokines. These cytokines are also cause leukotrienes because they are required for rest of the actions. Okay, so we want to do something with these. I think the drug calls monoclast or something like that. It's available in the market. Oh, it says over here. So we modify those leukotrienes. And these are the drugs which are available. Bind to the leukotriene receptor, prevent airway obstruction, inhibit the formation of leukotrienes, and prevent bronch. So you can see at that step, we want to stop that, and we're going to do that. Right? Because the asthmatic patient, there's not one shot. I think that's the basis of pharmacology. There's no one drug because there are a lot of mechanisms. And you have to, the more complicated it gets, the better it is for you and me because then we can come up with other lines of drug. So in the in the cytokines, we can go for IL-4, we can go IL-5, IL-5, but I'll just put them together, leukotriene modifiers, okay? And these are the two drugs available in the market right now. I remember many, many years ago, I used to talk about that, but they are there right now. So they bind to the leukocyte receptors, and then we do whatever that needs to be done to it, right? The other line of drug are simple antihistaminics, you know, same old. Why? Because histamine is the major, you can see from here, the major, what do you call it? Where do you put histamine? Oh, there you go. The major granule release, the bigger one, histamine. You know, vasodilation. So we use antihistaminic, right? But it is, so Allegra, loratadine, you know, they also have this effect over here in terms of this drug which is available. Primary act by blocking H1 receptors, histamine receptor, inhibit smooth muscle contraction, 2 action. We can give it allergic rhinitis, skin diseases, the hives, and some rashes. So you can see we can stop many of these drug reactions that people come by just giving them a better form of antihistaminic like drugs. Okay, and then the lifesaver, right? All but the biggest lifesaver that we have for everything that goes bad in medicine is corticosteroids. Stop the game, you know, anti-inflammatory, right? And we have tons of them, hydrocortisone, prednisolone, and so on and so forth. Very potent anti-inflammatory drug. But again, it couldn't be used for long term. It has side effects, has a lot of issues, but it is an emergency drug. So you have to make sure that you just use it in emergency and not use chronic. If you do use chronic, then they have other problems. You're going to overdo, right? And then again, it has immunosuppressive activity, because what it's going to do is that this is going to stop all of it. So all these things from here, you know, all the immune response that we talked about is going to be stopped. So what is the major danger if you do that? If you just kind of stop the whole immune response, what is a big problem that you can expect? Because body will never know to save you from infections, from cancer, increase the likelihood of infections. If you use chronic use of steroids, very high chances of you having infections, right? And if you remember the signaling pathway, the other day I told you, this acts to the gene transcription. So there were 3 genes we talked about in signaling pathway: NF-kappa B, AP1, right? These are last 3 genes that go in the nucleus. They are stopped. So these are the classical drugs we give in asthma, allergic rhinitis, urticaria, eczema, without even knowing the cause of that. So you can see a bigger picture in this case is that it's all come in allergy. You have to understand the antigen comes, presented to antigen presenting cell, it presents to a T cell and B cell, T cell produces cytokines, B cell is going to produce antibodies, what antibodies are required, and then how we treat with them, and how we manipulate the whole sequence. If you do something in the beginning, like for example, in the beginning, right, at the very first step of the antigen initiation, you know, so all the way from here till the end where you have clinical features, right, to the antigen, avoid the antigen from here, you know, and then you can stop this reaction, and then if you're not going to do anything for this thing, then of course you're just left with to do the symptomatic clinical treatment. For anything, whether it's a small itching, if it is a skin disease, is a drug reaction, is it asthma, is anything which is a food allergy, skin allergy, you name it. But the whole sequence is that this is what we do, and this is what the concepts are. Most of the questions in the final, even immunology, are gonna come from this table, mostly for, this is like physiology, I expect you to already know that, but this is something that from here onwards, Fc capsilon R1, antigen cross-linking, antihistamine, leukotriene modifier, you should know leukotrienes are cytokines, and cytokines IL-4, yesterday I talked about IL-4, because you need to have IL-4, which is a Th2 type, cytokine, which is anti-inflammatory, and that's required to produce antibodies. There you go. Any questions? And I was told that a lot of questions on Applex on allergies, hypersensitivity. This is something every drug, even if you don't remember the side effect of the drug you could just write allergy and it's going to be true. Right? All the way to the immunotherapy, bronchodilators, anti-diabetes bronchodilator, mast cell stabilizers, leukotriene modifier, antihistaminics. So if you do like 1, 2, 3, 4, 5, 6, 7 lines of drugs, all the way from a very simple rash to a very complicated, shock. Okay. Any questions? So I would advise you again is that either it's same old concept. Read the lecture before or read after me. So that these things remain, because they're going to come over and over. They're going to ask you one form. Even if I'm not able to ask you everything, I just try to teach you everything.